Hi, friends. Today we'll discuss a very important and commonly tested topic, the approach to thyrotoxicosis. First, let us clear a very common confusion. All patients with hyperthyroidism are thyrotoxic, but not all patients with thyrotoxicosis are hyperthyroid. Thyrotoxicosis simply means a clinical state due to high circulating thyroid hormone levels, irrespective of the source. Hyperthyroidism specifically means overproduction of thyroid hormones by the thyroid gland itself. So conditions like Graves' disease and toxic multinodular goiter are both thyrotoxicosis and hyperthyroidism. But thyroiditis or exogenous thyroxine intake cause thyrotoxicosis without hyperthyroidism. This distinction is crucial because treatment differs completely. Now let's come to the clinical presentation. A patient presents to OPD with palpitations, tremors, heat intolerance, anxiety, or weight loss. At this stage, the provisional diagnosis is thyrotoxicosis, not hyperthyroidism. Only after confirming that the thyroid gland is actively producing excess hormone do we label it as hyperthyroidism. An important teaching point, thyrotoxicosis does not always present classically. It can hide in plain sight. Some patients present with lone atrial fibrillation, especially elderly patients. Some have apathetic hyperthyroidism, with lethargy rather than hyperactivity. Others may present as PUO, malabsorption, hypokalemic paralysis, pruritus, ADHD-like symptoms, or tall stature in children. Absence of classical symptoms can delay diagnosis, so keep a high index of suspicion. Now let's come to an extremely practical biochemical concept. The thyroid gland normally secretes much more T4 than T3, in a ratio of roughly 4:1. In thyroiditis, no new hormone is synthesized. There is only release of stored hormone. So more T4 than T3 is released, mimicking normal physiology. As a result, the T3 to T4 ratio is low, usually less than 15:1. In contrast, in hyperthyroidism, especially Graves' disease, there is a disproportionate rise in T3. This happens due to increased conversion of T4 to T3 by type 1 deiodinase. So here the T3 to T4 ratio becomes more than 20:1. This ratio has high specificity but low sensitivity. So if it is high, it strongly favors hyperthyroidism, but a normal ratio does not exclude it. Now let's move to treatment. Initiation of carbimazole. Dose selection should be based on T4 levels, not TSH. If T4 is more than 20 micrograms per deciliter, start 30 to 40 milligrams per day. If T4 is less than 20, start 20 milligrams per day. Doses beyond 40 milligrams offer no added benefit and only increase side effects. Carbimazole is usually given once daily. In severe thyrotoxicosis, it can be divided into 2 or 3 doses because the hyperactive thyroid clears the drug rapidly. Euthyroidism is usually achieved in 6 to 12 weeks. Once T3 and T4 normalize, reduce the dose by 5 to 10 milligrams every 2 to 3 months, guided by serial T3 and T4 levels. Continue a maintenance dose of 5 to 10 milligrams per day for a total treatment duration of 18 months. Why continue even after normalization? Because carbimazole has immunomodulatory effects. It reduces MHC class II expression and intrathyroidal inflammatory cytokines, thereby reducing relapse risk. Now let's discuss case scenario 1, a 35-year-old woman with classic symptoms for 6 months, and a grade 2 diffuse goiter. Her thyroid profile shows high T3 and T4 with suppressed TSH. Diagnosis is Graves' disease. She is started on carbimazole 40 milligrams per day with propranolol. At 6 weeks, her T3 and T4 normalize, but TSH remains suppressed. What do? This is a very common mistake area. Do not wait for TSH to normalize. In early follow-up, T3 and T4 guide dose adjustment, not TSH. TSH recovers slowly due to prolonged suppression of thyrotropes. So the correct step is to reduce carbimazole to 30 milligrams per day and monitor T3 and T4. Now case scenario 2. A patient on carbimazole 20 milligrams for 3 months has elevated T3, normal T4, and suppressed TSH. Here, do not reduce the dose. T4 normalizes first, followed by T3 and finally TSH. If T3 remains high, the dose should not be decreased. It may even need an increase. Tapering should be attempted only after both T3 and T4 normalize. Now, case scenario 3. A patient on carbimazole 30 mg presents with hypothyroid features at 6 months. Labs show low T3, low T4, and high TSH. This happened because the drug was not tapered in time. After starting or adjusting therapy, thyroid function tests should be reviewed at around 6 weeks because early follow-up guides dose titration, prevents overtreatment, and avoids iatrogenic hypothyroidism. Stopping carbimazole and starting levothyroxine is not correct because she has received only 6 months of therapy and relapse risk is high. The correct step is to reduce carbimazole to 10 mg per day and recheck TFTs in 4 to 6 weeks. Block and replace therapy is generally avoided. Finally, when do we stop antithyroid drugs? Antithyroid drugs should not be stopped early just because the patient feels better or TFTs look normal once. In Graves' disease, the standard duration of therapy is at least 18 months. Stopping before this significantly increases the risk of relapse. Second, before stopping ATDs, there should be biochemical euthyroidism. That means T3, T4, and TSH should all be in the normal range. Remember, TSH is the last to recover, so stopping therapy before TSH normalizes is a common mistake. Third, the patient should be stable on a minimal maintenance dose of antithyroid drug. For carbimazole, this usually means 5 to 10 mg per day. If the patient still requires higher doses to remain euthyroid, it suggests ongoing disease activity and therapy should be continued. Finally, if available, TRAb levels are very helpful. The disappearance or normalization of TRAbs is associated with a higher chance of remission. Persistently positive or high, TRAb levels predict relapse after stopping ATDs. So, to summarize in one line, antithyroid drugs can be stopped after 18 months. When T3, T4, and TSH are normal, the patient is stable on low-dose carbimazole, and TRAbs have disappeared or normalized. Remission is defined as maintenance of euthyroidism for at least 1 year after stopping ATDs. Remission rates range from 30 to 70%. If hyperthyroidism persists or relapse occurs, options include long-term low-dose antithyroid drugs, radioiodine ablation in selected patients, or total thyroidectomy and large goiter, active Graves' ophthalmopathy, or nodules. So to summarize, always differentiate thyrotoxicosis from hyperthyroidism. Use T3 and T4, not TSH, for early dose adjustment. Taper carbimazole carefully. And remember, failure to taper on time leads to hypothyroidism.